In this chapter, we'll be looking at the shoulder and the injuries that can occur at this joint. The shoulder has a high degree of mobility and stability due to the function of the rotator cuff and the relationship it has with the in-joint capsule and the scap stabilizing muscles. Sports that involve overhead activities are extremely susceptible and overuse injuries. These sports include baseball, softball, tennis, volleyball, etc. Where athletes lack in conditioning their shoulder is that they do not strengthen through a full range of motion. Strengthening in flexion extension, abduction, internal and external rotation, and scaption, etc. is extremely important to the integrity of the shoulder. A major factor in shoulder stability is having strong scapular muscles such as the lats, rhomboids, traps, etc. These influence scapulohumeral rhythm and helps share the force load with the rotator cuff muscles. Scap muscles are also a main cause of rounded shoulder posture, which can place more stress on the structures of the glenohumeral joint. Warm-ups that include dynamic stretching and band work should be done before explosive arm movements in order to prevent injury. Instructing athletes on proper falling mechanics is crucial for contact sports. Falling on an outstretched hand is what we call a fouche mechanism of injury, which occurs when an athlete falls and tries to catch themselves. Athletes are better off letting their trunk take the brunt of the force or folding their arms in. It is hard to break individuals from the habit of catching themselves when falling. Analyzing athletes' mechanism in throwing or hitting should also be performed to identify improper mechanics that can lead to injuries such as biceps tendinitis, bursitis, impingement, rotator cuff strains, etc. The different phases of throwing have been heavily analyzed to understand the different motions involved and how the muscles interact with each other throughout movement. Understanding these phases and the different stress it puts on the shoulder greatly influenced having a pitch count in baseball in order to decrease the risk of injury. There are 5 phases of throwing, with each having its own motion involved. The wind-up is not normally associated with many injuries as the motion does not require much power or acceleration. The cocking phase and acceleration phase can cause extreme pain with the rotator cuff strain, or an injury due to the required maximum external rotation. The deceleration phase is normally the phase where most soft tissue injuries can occur, with the eccentric contraction of the rotator cuffs and rhomboids to slow the humerus and scapula. Aroldis Chapman is an MLB player that threw a 105.8 mile/hour pitch in 2010 against the Orioles. The average fastball speed is 95.6, with many starting pitchers able to throw around 100 to 102 miles per hour, but no one has beaten Aroldis Chapman's record in over a decade. The video shows a brief breakdown of his mechanics. As always, an in-depth history needs to be conducted in order to narrow down the possible injuries. Training changes are extremely important, especially in baseball and softball, as they normally put in more hours with pitching practice added to normal practices. It is also extremely common for individuals to have previous histories, and it is important to know about not only the major injuries, such as tears and dislocations, but also chronic injuries of bicep tendinitis, rotator cuff strains, triceps tendinitis, etc., as all of these injuries, once sustained, can reoccur very easily. Muscle tone and bony structures should be relatively symmetrical. Also notice the position of the arm when being evaluated, as it will normally be held in a position that relieves the pain. Other chronic malalignments must also be noticed, such as winging scapula, scoliosis, forward head posture, etc. Palpation for point tenderness, integrity of bone structure, muscle grounding, etc. should be performed simultaneously and bilaterally in order to notice any differences between the two. Always remember to palpate into the scapula for any shoulder issue, as well as in order to assess the entire shoulder complex. There is a plethora of special tests that can be performed to help assess the structure that are involved in an injury. Some of them include apprehension, Mears, Hawkins-Kennedy, empty can, and Speed's test. Remember that even though these tests can have a high specificity or sensitivity, it does not mean that they are official diagnostic tests. Any indication for a tear or a severe involvement of a structure should be sent for imaging and official diagnosis. To test for sternoclavicular and acromioclavicular stability is to apply pressure in different directions to assess for laxity and pain. The clavicle should also always be palpated in a shoulder injury to assess for a fracture. These palpations should be performed bilaterally. Clavicle fractures are typically caused by a fouche mechanism or falling on the tip of the shoulder. These are largely common in football, soccer, and lacrosse sports. It normally occurs in the middle 1/3 of the bone. The athletes will be present holding their arm to their chest and with their heads tilted to the side of the injury. Deformity is very common with localized swelling. If the fracture is not displaced, then the individual can be placed on a sling or a brace for 6 to 8 weeks heal time, and then can start rehabilitation. If there is a displaced fracture, surgical intervention is needed, and this is considered a medical emergency due to the surrounding vasculature and the risk of them being injured. Circulation should be assessed if the fracture is suspected. These show the fracture of a clavicle and how it can present visually. If you would like to understand the surgery of a clavicle, enjoy this video. However, this video is a real surgery, so proceed with caution. Humerus fractures occur often due to a direct blow or Fuchs mechanism. A humerus shaft fracture can show a deformity but isn't always common. A proximal fracture of the humerus can be present with a dislocation but can also be caused by a direct blow or Fuchs. This injury must be immediately splinted and referred. Always watch out for signs of shock, as this is a common injury that shock is an addition to. Return to play time can be anywhere from 2 months to 6 months depending on the severity of injury. These pictures show the different fractures that can occur and what surgical intervention can look like. ST joint sprain is normally caused by blunt trauma to the area or from a blow to the posterior shoulder and is graded by the severity of the injury. A full dislocation of the ST joint is a medical emergency due to the vasculature surrounding the area and should be referred for imaging and potential surgery. Individuals that have a stable joint sprain is immobilized for a number of weeks before starting rehab. The video discusses this SE injury that Tyreek Hill suffered and discusses the management of that injury. AC sprains are graded relatively similar to an SE sprain. This is again caused by a direct blow, Fuchs, or an upward force of the humerus. An AC sprain is going to limit abduction and adduction of the shoulder, with pain commonly being presented with shoulder flexion as well. Immobilization is relatively short, between a few days to 2 weeks. Rehabilitation is extremely important to improve range of motion and stability of the shoulder. When the athlete is returning to play, additional padding can be used to protect against direct blows to the area. Reoccurrence of the AC sprain is common. The video breaks down the different grades of an AC sprain in reference to the injury sustained by Jimmy Garoppolo with the Patriots. Glenohumeral dislocations commonly occur anteriorly as a result of the arm being injured in an outstretched position. The shoulder can be dislocated inferiorly, but it is uncommon, and mostly seen in motorbike accidents rather than in sports. The signs of a dislocation is a flattened deltoid muscle and prominent humeral head in the axilla. Reduction of a dislocation should be done as quickly as possible. Physicians will commonly attempt to relocate on the field. Depending on the physician's orders, an AT can attempt to reduce a shoulder dislocation as well. If the shoulder cannot be reduced after 1 to 2 attempts, then the athlete should be immobilized and sent to the ER for reduction and imaging to rule out a fracture. The picture shows a shoulder dislocation and how it can present visually. The video dissects the injury suffered by QB Mitch Trubisky. Rotator cuff strains are extremely common, especially in overhead athletes. Acute tears are commonly seen in young adult athletes. Chronic full-thickness tears normally occur in older individuals. There's a significant loss of strength and can present like impingement. Treatment of a rotator cuff strain includes rest for a day to a week and then progressive strengthening over the course of a few weeks to a month to 2 months. In baseball, it's extremely important to incorporate a throwing progression at the end of the rehabilitation process to allow these muscles to slowly adapt to the volume of throws.